Hello, everyone. We're going to take a few moments to let everyone join the webinar. Dr. Saketkoo will be joining us in just a few minutes as well. So the numbers are rising. People are coming into the webinar room, and Dr. Saketkoo is back. Dr. Saketkoo, can you hear me?
Hi.
Can you hear me?
Yes, I can hear you now.
Oh, great, great. Okay, good.
Can you
Okay,
see
I'm
me?
just letting people join and then we'll get started.
Good. 30 seconds, filling my water glass. Is that okay?
Yes, that's fine. All right, I'm going to go ahead and get started. Hello and welcome everyone to the Myositis Association's Ask the Doc webinar series. I am your host, Rachel Bromley. I am TMA Senior Manager of Patient Education, Support, and Advocacy. And today we have the honor of speaking with Dr. Lesley Saketkoo. And Dr. Saketkoo is a member of the Medical Advisory Board for TMA and is also trained in pediatrics, internal medicine, and rheumatology. She is director and founder of New Orleans Scleroderma and Sarcoidosis Patient Care and Research Center. She is a clinical researcher in multi-organ system diseases and has a strong focus on muscle and cardiopulmonary manifestations. Her research focuses on disease-modifying effects of exercise, clinical trial design, identifying patients' priorities, and developing research tools with patients, including targeting self-management strategies, yoga, dance, and singing for lung health rehabilitation, as well as mindfulness practices. Thank you so much for being here, Dr. Saketkoo. You're on mute.
Hi, it's wonderful to be here. Thank you, Rachel. Yes, I've been looking forward to this, right? Something I feel passionate about. The TMA, yes, of course, but also patients being able to understand the use of prednisone and being able to advocate for themselves. It's a really important, it's a critical knowledge point and a point of self-protection.
Okay, well, we have some questions that were submitted. And then if you have a question for Dr. Saketkoo, please put it in the Q&A and we will get to it. But first, Dr. Saketkoo is going to take a little bit of time to share some information about her work.
Oh, about my work. Okay. Well, I guess in relation to myositis, a lot of my work has to do with, yes, muscle involvement, but also understanding cardiopulmonary involvement in myositis. Another large area of this work that I love is, and that's very meaningful to me, is working to understand patients' priorities and understanding about the disease through patients. And
I actually had a question about that, Dr. Saketkoo, when because it's in your bio also. What do you mean by helping them discover their patient priorities?
So, as an example, we as clinicians might think something is super important, and we might put a lot of dollars and time and energy in an area that we think is important, but it ends up that something else was much more important to patients. And like, for example, we've seen that in scleroderma, and we did some GI studies from focus groups, and understanding how GI symptoms were really so devastating in so many aspects of their life, and many patients were rating it as a bigger problem than even a lung disease, which we as clinicians think, oh my God, the lungs, we have to work on the lungs. So that's one example. And another example that we've learned a lot from patients is that if we're looking at overall quality of life, sometimes that brings a patient closer to being well than the actual issues that we tend to be concerned with, which are abnormalities in physical structure, biochemical pathways, etc. And so, and I think now we're in a dawning where there's really that respect for patients, and there's a meeting of the there's a meeting of respect for both of those points of view, that we need both points of view to tackle the most important things first. It's because patients are experts. And so that's where this comes from, is listening to patients. This is their lives, and they have a right to say what are research priorities and what are priorities in terms of clinical care. And that also talks about shared decision-making, of which self-advocacy is really important. And it's important to recognize that a lot of clinicians, physicians, etc., are not skilled, they're not trained in shared decision-making and how to explore choices with a patient. And then once information is shared, working with patients to get to the best solution for that particular patient. And so sometimes, because we are not skilled like this and we just learn along the way, sometimes we need guidance from our patients to let us know when we're doing it right, when we're over speaking, when we haven't spoken enough. And it's part of a part of developing some skills in self-advocacy. And so, so that's pretty much.
So if we have anybody who's not an expert yet because they're just recently diagnosed, can you tell them basically what does a rheumatologist do and why would they need a rheumatologist as opposed to a neurologist?
Okay, so rheumatologists tend to deal with all parts of the body. You know, we kind of, you know, in internal medicine, you know, if an internal medicine person deals with the whole body except for the eyes, but in rheumatology, as opposed to cardiology that deals with the heart, pulmonology that deals with the lungs, neurology that deals with nerves, nervous systems, we're meant to be cultivated to be nuanced, to understand multiple organs, system involvement, and therefore we can care for eyes, we can care in the realm of autoimmunity and inflammation and scarring, and we can and even glaucoma, and we can care for the skin, we can care for the heart, the lungs, you know, because a lot of autoimmune manifestations, the kind of even involve the hair when we think about alopecia with hair loss, right?
Mm-hmm.
But when you have a disease like myositis, when you have a health condition like myositis, it's super important to get plugged into a myositis center, and it's becoming increasingly common and acceptable for a person to have two rheumatologists, a general rheumatologist, a community rheumatologist, and a rheumatologist that is recognized for treating or having a specialization in myositis. And I know the TMA is working in that direction because the care can be very different from a group of people that deals with a rare health condition all the time. And so we can help foresee complications that are around the corner because we can see the signs. Whereas if you don't have a high volume of experience on a regular basis, it's easy to miss these things, and then it becomes difficult to steer out of trouble.
My question is then, does that mean you have patients with all kinds of myositis?
Yes, you mean
You like dermatomyositis too?
In IBM? Yes, exactly. So these
that's great.
are patients with, you know, and I have some a cadre of patients with juvenile dermatomyositis as well, because I'm trained in pediatrics. So yeah. And so we do encourage that. We do encourage patients to kind of seek concurrent care with a general rheumatologist, and oftentimes the general rheumatologist is really glad to have somebody else. These are not so these conditions are highly individualized also, and so they can get complicated, and so many general rheumatologists are really glad to have an extra mind, and I'm always glad if I like to see patients in tandem with other people, because it really helps to understand the nuances. And somebody calls me out on, like, oh, did you happen to see this? And I'm like, oh, I didn't see that one from 2005. That's important for now. That result was important for now. So I was, because it's all about teamwork and patient being part of the team too, and hoping for a collaborative experience is always a great thing in rare, complex diseases.
Okay, well, let's get to the questions. Again, put any questions you have in the Q&A box. And we're starting out with someone who has IBM and would like to know if there are certain foods or drinks that they should definitely not consume. And are there any foods that you do recommend to reduce inflammation?
So I am not a nutritionist. I do have strong feelings that I think possibly related to, well, there's some things that I'm going to say which are definitely related to evidence and research. The one is exercise helps to condition the microbiome, which is the bacteria that lives in our gut that regulates our brain. There are third brain, but we think that's really so. Conditioning the microbiome is one of the things that can really make a difference in inflammation and cancer recurrence, and cancer occurrence and cancer recurrence. And exercise impacts the microbiome, and also our food choices impacts the microbiome. And so on that level, and there's a good amount of information about what kinds of food, like low processed foods, for example, more plant-based foods. If you are eating meat, you want to have meat that was grown in a healthy way, because we really are what we eat. If we eat meat that has been in a situation where they've been super stressed with bad life experience, and had tons of antibiotics, which most of these commercial meat production places have, and sometimes the method of slaughter is also non-hygienic, but just it's hygienic enough to pass, standards, right? And so that exposes folks to microbiome issues that are inherent in these animals, that are living a very stressed life, which probably, so those are the things that are really super important to pay attention to: healthy choices, healthy living, to avoid eating those types of byproducts. Buying healthier food is a bit more expensive,
Yes.
but we don't need as much of it because it's probably healthier. So, and more nutritive.
Okay, someone asked about if you could speak on the use of prednisone with IBM.
Okay, so I'm not a fan, and I think most folks these days are not. It's hard to have a condition like IBM, and folks, and I think also this is possibly very individual too, that some folks feel that they do better with a little bit of prednisone, and maybe that's so. And so we have to just try to listen and make decisions together. The other issue is prolonged steroid use can affect muscle. That's a paradoxical issue. So you can get what's called a steroid myopathy. So the muscle becomes atrophied. Just like you have all these wacky skin changes that occur, these same processes happen in the muscle, and not everybody has them to the same extent as other folks, but it still does happen. So, I really honestly, if you have IBM, I'm going to say it again, get dual care. First of all, in terms of neurology and rheumatology, but think about having a general neurologist, general rheumatologist, plus that specialist neurologist or specialist rheumatologist that is dedicated to IBM. I see far less IBM than my colleagues at Hopkins, for example, or in some other institutions, or Ellie Nadaf at Mayo. I'm sure he sees many more IBM patients than I do, but to get care with people that have an understanding of the tempo and of the individuality per patient, and can be sensitive to that, and also. The other thing that's really super important if we're talking about touching upon treatment in IBM is having access to clinical trials. And even if you don't live close, I know, we have a center, and we're often flying in patients to be part of a study like every month to come in for visits. So a lot of sponsors are willing to do that. So it's worth really taking the time to investigate concurrent care.
Thank you. This is a little bit of a specific case, and again, I do know that you can't always give a complete answer when you don't see somebody's records, their full records in front of you, but we're just going to go through and see what we can address. Okay. So this is a 68-year-old who ran a 41-mile race in September of 2020, so very active. And then in October that year became symptomatic and was diagnosed with DM in February of 21. With treatment, they are now able to walk 10 miles and are now just regaining the strength to maybe run a couple of miles. And their question is there research or incidental information that shows intense activity can trigger the disease or a flare? And is there any caution I should be aware of moving forward with my exercise regime?
What a great question. We're about to publish information on safety and exercise in
Oh, really? When do
myopathy.
you think
Yeah,
that'll be?
the ICERS group. Probably a few months, we
Okay.
still have to
Okay.
submit it, but we're finishing off our paper. And actually, Dave Moschel, who's the TMA Board of Directors, is a co-author on this paper, as are several of our TMA board members, MAB members, Medical Advisory Board members. And this is an evaluation of looking at the literature. First of all, again, we're coming back to that word individual. There's no evidence to suggest that exercise is harmful. That modulated exercise to the capacity of a patient that they're able to do is harmful. In fact, it's the opposite. It looks like from studies that have been done, especially at the Karolinska Institute, where Helen Alexanderson, Ingrid Lundberg, and Malin Reckard they've done a number of studies to demonstrate that exercise is not harmful. In fact, it reduces inflammation, and it engages reparative pathways of recovering muscle. And the sooner somebody gets into an exercise program that's appropriate for them, the sooner that they're able to recover in the everyday world as well. Meaning how we move through our lives, you physically get through our lives. And it also gives a sense of well-being. So in terms of high intensity exercise, Helen Alexanderson is doing just that. She's studying right now on HIIT, high intensity training, interval training. And so and they wouldn't be doing it if they thought it was harmful. So it's
Right.
great.
I'm so excited about that because I'm hoping that, she's on our MAB now, as you know, and I'm hoping for the APC, we can talk about that and talk about your paper. It'll be out by then. And that's just
Yes,
exciting news.
it is.
High intensity training, because we have a lot of former athletes that I've noticed since I've been at TMA that were, really involved with exercise and learning how to manage that type of their life and still find joy doing that.
Yes, yes. Rachel, there's
Mhm.
2 points I'd like to add still.
Uh-huh.
So one of the things before you start a moderate intensity exercise program or a high intensity exercise program, everybody should be screened for, cardio pulmonary involvement, just to make sure that you don't have any heart involvement, and exercise should always be modulated to that. There's also a caveat that I'm going to say, like if you're really feeling bad 48 hours after you've exercised, maybe you have done too much, and you never want to overstretch or over exert a joint, especially if you're still having inflammation, because when we have inflammation is like a soup, and it's like an acid soup, and it makes our ligaments um, less strong and stabilizing. It makes them looser, and so therefore the joints are not as stable. So, and without that backup of the muscle also being fully at its best, then we that's another hit to joint stability. So it's important just to keep that in mind. The other thing that I want to say is that as patients, patients are advocates for other patients and to help people who think something's wrong with them but don't know what it is yet. And I think we've seen a lot of that in the last 10 years with the Myositis Association and patient support groups and getting the word out and awareness. And people who don't yet have a diagnosis, they know something, they're not crazy, they know something's wrong with them. You brought up athletes, and I think this is another sphere of our research, which is patient focus groups on their experiences of getting diagnosed and exercise. And one of the things that came up is patients said, I am an athlete, and they would say to the doctor, I am an athlete, and I used to outrun everyone else on my team, and now I'm falling behind. Something is wrong, and I can feel it, and this is what I feel. And then the physician does a muscle test, and they're like, well, you seem pretty strong to me, and they know, but they know something is wrong. So these stories are important to circulate. If you have a story like this, then you're on, social media, or these kinds of stories help lend a piece of self-advocacy for those patients that are yet involved, yet diagnosed. When we have a focus group and people talk about their journeys, there's several points along the journey that they're like, oh my God, you had that too. You experienced that too. It's just like it's a sense of sublime acknowledgement of some painful time in their journey, but also it's, as a physician listening to this, I'm learning. And so that means that if somebody is experiencing this and they hear this story, they may learn from it and be able to advocate better for themselves, and say, well, yeah, I'm not crazy. Something really was wrong with me. And this is a great source of regret amongst patients, that they let a year or two go by getting worse, knowing that, but they didn't have the vocabulary, and they didn't have access to other people's stories.
Mhm. Okay, let's see what questions we've had come in. And don't worry, we will get to everybody before we are done tonight. But what is meant by high intensity exercise? Could you give an example?
Okay, so this is what we like to say to help patients. You can do this by measuring your heart rate, your resting heart rate, and then your heart rate when you're exercising and how high it gets, and look at recovery time, blah, 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 blah. But the simple way to do it, and we talk about this, and we will talk about this in our paper. And actually, what I could do, I can send you a link to our scleroderma and exercise paper, because it has this written out in it. If you'd like that, you can email it to folks. And that has a number of our myositis medical advisory board folks on the scleroderma paper as well. But the way to know intensity is, sometimes you can do this very easily by noticing how you can talk when you're exercising. So a low intensity exercise is something whereby you can still have a, kind of regular conversation, maybe slightly bit difficult. But moderate intensity is where you are doing your exercise and you're able to hold a conversation, but you can feel it, High intensity is where you're exercising, but you're like really like sort of gasping as you're talking, kind of like, yeah, I got to the point where I was, that kind of thing. So you can tell by that scale of how, and here's the very important thing. We're back to that word individual again, because what's high intensity for me is not going to be high intensity for you. What's moderate intensity for you isn't going to be moderate intensity for me, because everybody's different. And so, and everybody's at a different place. So the same amount of exercise is going to be different in different people. However, the more we do that exercise, the less intense it becomes. But we can always amp it up. So by watching your breath and watching how you can talk when you're breathing, also how to intensify that aerobic exercise that you're doing. Does that make sense?
It does. And if I'm looking away, I'm so sorry. I'm just dealing with something with my daughter, and then also picking the next. I've got a teenage daughter, so that's all I have to tell you. But she's fine. But okay, so let's see. We had a request from someone who knows that you are very excited about and use singing to strengthen lungs, and they wanted to hear a little bit more about that.
I wonder who that is. Was that somebody at the workshop, at the conference workshop?
No, it's somebody new.
Oh,
I think.
Yes. Okay. So I think singing is really important for a number of things. And Helen Alexanderson, who is probably the premier physical therapist in myositis, agrees with me. She's also a choir leader and a singer. But, singing, there's so many things you could say about it. There's just so many things you could say about singing. And it exercises one of the largest core muscles in the body, which is the diaphragm. And so, and the diaphragm, when you use muscle, muscle is what helps to regulate the body's inflammation levels and respond to. That's why exercise is so good for inflammation and good medicinally for lots of other things like blood pressure and cholesterol and glucose uptake by muscle. For that reason. Another reason is that rhythmic motion of the diaphragm also helps to massage the organs in the thoracic cavity, but also in the abdominal cavity. That can be really important for GI conditioning and also for neurohormonal conditioning, like the vagus nerve, and also the baroreceptors in the thorax that regulate blood pressure and heart rate. So that pressure differential is causing massage, and that's a great thing with exercise and with singing. And singing is a wonderful thing to do. Another issue with the diaphragm is when we strengthen the diaphragm, there's been studies to show that core strength improves because it's a core muscle, balance improves because it's a core muscle, and also back pain is reduced because it's a core muscle. And so some of the other things that singing can help with is some people with myositis, could be as much as 20% of people with myositis have dry mouth and dry eyes. And exercise helps with glandular function, whether that's the skin or whether it's glands in the skin or glands in the salivary glands. The other thing that is important in singing is it also helps to bring circulation to the mouth and to the face. One of the things that we're looking at now in systemic sclerosis, and this is probably true in several other autoimmune diseases, is the mouth is affected. And the more that we can bring circulation to the mouth, the better dental health is probably going to be the result. What else do I want to say? Oh gosh.
I know there's so much.
The other thing about singing, it's self-regulate. It's a form of self-regulation, self-soothing, and which has a biochemical effect on our psychiatric outlook and our psychological outlook and our well-being. But the other thing is, oh my goodness, something really important I wanted to say. Well, if it comes back out, as I was talking about.
We can circle back around.
Singing
Let's
is
see.
wonderful. It's really,
Yeah.
it's connecting. It's wonderful.
Let's pivot quickly. We have someone that has gout and they want to know how gout can affect their IBM.
Well, I am not sure of the I don't think anybody is sure of the the biochemical pathways and if there's issues there. I think in terms of actually having flares, we think exercise is good for everybody, and if anyone's in pain, it's hard for them to want to exercise, and that's a really important consideration with gout. That if you're having flares, if it's not controlled, you're not going to do exercise. And we have reason to believe that if we begin a reasonable amount of exercise in IBM, and especially early on in IBM, we can decelerate, we can slow down the process, and maybe even stabilize it. We're working on that, but it's so important to feel physically okay. The other thing about gout is that one of the things about exercise is it helps our cardiovascular system. And, gout can be associated with cardiovascular issues, depending on the type of gout you have. And so that's one reason to kind of control the uric acid, the levels of the uric acid. And so if you're somebody that has gout and you have what's called tophi, which are those kind of nodules that happen, it means that usually your uric acid is fairly high, even yeah. So it's good to get treated for that. So number one, maybe improves the cardiovascular profile and cardiovascular health in the future. Especially because, as IBM progresses, we become less active and we don't necessarily have that resource for intense activity. And then the other thing is because if it interferes with how we feel, whether it's pain or whether it's because of where the nodules are, then it's good to try to get those resolved. And the way to get those nodules down, for example, is by therapy and getting the uric acid level in the blood down. And that's about as much as I know about gout. This is the problem with being like very specialized. I don't see gout patients anymore, or, and so.
No, that was great. Thank you. Let's move on to dermatomyositis. This patient has DM, and they continue to thrive through their 7-year duration of having it. They're conscious of their diet, mostly plant-based, and exercise approximately 1 hour a day. They also have concurrent CVD, which I assume is cardiovascular disease, right? CVD?
Possibly.
Well, yes, because they said they had 4 stents with no cardiac
Yes.
event. So it's definitely cardiovascular
Yes.
disease.
Mhm.
I have been told the development of this is independent of dermatomyositis, and I don't quite believe that. Can you comment?
So how many years of
7.
7? Usually cardiovascular disease is maybe a later finding in people with autoimmune diseases, like lupus and rheumatoid arthritis, maybe because of the ongoing inflammation that may not have been addressed. It's hard to say, honestly. But again, I'm going to leave a couple pearls here for everybody. It's very important to control disease activity. And that means controlling inflammation, and exercise helps and is a very important adjuvant to pharmacologic treatment, but it's very important. I'm very, if I could not give medicine to patients, I would, because I believe in people, healing themselves as much as possible. But in these types of health conditions, it's just not an option. It is just not an option, and if there's anyone saying that it is, they're full of, what. And exercise is important, and all these other adjuvants like singing and good diet are important. But if you go untreated, there's going to be consequences, and not just because of the actual underlying condition like myositis. It's going to have a lot of fallout in terms of cardiovascular disease, bone issues, etc. And when I say treated, we were going to talk about prednisone. Prednisone is for a short time only. You should never be left on prednisone indefinitely, because that's going to ruin your body in the same way that not getting treated will ruin your body.
What about the use of methotrexate?
Okay, well, if methotrexate is enough for you, for your situation, and so that the level of disease activity that you experience is quelled, absolutely quelled on methotrexate, that's awesome. That's awesome. That's lucky. But more often than not, my patients need methotrexate plus maybe mycophenolate, or maybe once in a while rituximab. Just try to assess this every few months to see how folks are doing, and if they need an extra help with some rituximab. But it's not uncommon to need combination medications in this. But if somebody's disease activity is controlled with methotrexate alone, wow, that's awesome. And I know that there are people out there that are that fortunate.
We got another question in about treating your DM patients with IVIG, cutaneous versus muscular symptoms. Do your patients on IVIG typically get infusions at home or at the center?
I do both. I try, well, it was during COVID, tried to get them either at home or at a dedicated center rather than coming to the hospital. Now it seems folks are mostly coming back to the hospital, but I think home infusions are a good thing, as long as it works out for patients and their insurance. And insurance isn't, this day I think insurance really took a big hit, and they're maybe not so fond of doing these more convenient options for yeah.
No, yes, thank you so much. This person has polymyositis, and a slightly elevated SSA indicates that they may be at risk for ILD. They are interested in exercises that might help prevent or delay this development. They have muscle weakness, so they're limited to things that don't require much agility, good balance, or strength.
What about singing?
I know, right? Let's take it back to that.
That's really, singing, chanting. There's gentle yoga with a really good and thoroughly trained yoga teacher. Yes, I think those are really important aspects, and making sure one's underlying myositis is well treated, and the rest of the manifestations that might go with it, like if you have dermatomyositis. I know you don't, but if you had dermatomyositis, you'd want to make sure your skin is controlled, for example. And sometimes these things don't run hand in hand, but more often than not, if disease is well controlled and the dragon is kept sleeping in the cave, then usually we're able to keep the dragon in the cave snoozing without any other detrimental things going awry. It's a usual motif, not always the case, but most of the time that's the case. Staying well controlled in disease activity.
Sometimes I get these questions and I don't know whether I should ask them or not. So this one is one of those.
Sure.
Because this person is not diagnosed with anything yet. They say my daughter has leg pain similar to growing pains in her legs a lot. How do I know if this is a possible antisynthetase symptom in my daughter? She has broken 3 bones already.
Well, broken bones, fractures are not a manifestation that's considered to be part of antisynthetase syndrome. What would be important to look into is her bone density, and possibly, if she's had several fractures, there is a health condition called osteogenesis imperfecta, OI, osteogenesis imperfecta.
Mhm.
And a pediatrician should understand what's going on. And if you need to go to a specialty hospital, sometimes it helps. One of the things about physicians that work as generalists, they are really fighting on the front lines. And sometimes it's really hard to have the mind space and the time to kind of figure things out. And also because you see such a variety of things that it's sometimes hard to pick things up. And so I really have so much respect for generalists, general rheumatologists, general pulmonologists, general pediatricians. But you may want to go to a dedicated children's hospital to get an evaluation as to why this is happening.
Thank you. And we've got one final question. So if you have anything else you want to ask Dr. Saketkoo, please put it in the Q&A. This person is diagnosed with necrotizing myopathy, and they've been taking IVIG for almost 1 year. They've also used prednisone. They missed IVIG 1 one treatment and their CPK level went from 200 to 3,000. Is that because they missed the IVIG? Should they use mycophenolate? They're scared about the side effects.
So this is really good. These are really good questions. That means that it probably means like the skipping of the IVIG, and this, and were the symptoms, can I ask, can you type in whether the symptoms got worse when the CK went up? I imagine that they did. I just don't want to assume, because
Right. I don't know if this person is on the call or because I got this one through email. But if you are on the call, then go ahead and put that in. And while we're waiting for that, Pamela, I see that your hand is up. And since we are, doing great on time, I am considering opening your mic for your question because I think maybe you're unable to type. And I know that sometimes happens.
Yeah.
So, great. Pamela, I'm going to allow you to talk. Can you hear us? Can you speak, Pamela? Where'd she go? I really wanted her question. Maybe she put her hand up on accident. And she's like, oh my gosh, don't talk to me. Okay. This person wants to know, can a person have both inclusion body myopathy and also inclusion body myositis?
I think this is a great question because what it highlights is, we use so many words for the same thing, and you're going to see the word myopathy and what that really means. Myo is muscle. Pathy means something's wrong. It doesn't matter what it is. But inclusion body myopathy is probably inclusion body myositis, and myo, muscle, situs, inflammation. So, and even though it's not a strongly inflammatory disease, it's still called an inclusion body myositis, and maybe that's an effort to call it inclusion body myopathy to move away from this overly zealous description of it being inflammatory. Great question.
We got a great question that came in while you were talking, and that's why I got a big smile on my face. This person would like examples of good songs to help if you have ILD and want to use singing.
Oh my gosh. Okay. Great songs. Songs that, well, I guess it depends on, first of all, you have to listen to yourself and not overexert. I think with COVID, we've learned from singing with lung health about the in-breath and the out-breath. And, you don't want to overexert the in-breath. You don't want to overexert the out-breath. What do I love to sing? There's so many songs. Oh my God.
Is there something about like Broadway songs specifically that would be very good because, they seem to be really exerting themselves on certain notes?
I don't know about that. And that's not really been studied. The most important thing is to experience pleasure. And there's something involved with, and gently in the beginning, because you want to really connect with your diaphragm. You want to connect with where your breath is sitting. And when we're blaring out, it's like when we're blaring out a Broadway tune, sometimes it's sort of like overexerting your muscles,
Oh, okay. That makes sense.
And so kind of like listening to, it's even better to start small and then build up and not expect anything but feeling the pleasure of the sound and the vibration in your body and the movement of your rib cage as much as it happens to move, or the belly and the back, sort of like as a massage type of thing. And you can do things that you can do songs that kind of elicit longer note holds, exhalations, and you can, and this is where individuality and improvisation come in, because you could sing twinkle, twinkle You could sing Twinkle, Twinkle, Little Star, so if you kind of think of yourself as a jazz musician, twinkle, twinkle, little star, and you're also exercising the muscles in your mouth. So there's so much you can do. Do what you feel, find a song you love, and then, do a cover version. Do several cover versions. Yeah, do one for lullaby that you're going to do at night. Do the song that you need to do, the tempo, the rhythm, the cadence that you need to do when you're chopping your vegetables for dinner. Lots of different things.
Well, we're coming to a close. So do you have any final words that you would like to share with the audience?
Yeah. Treatment is important. Making sure you have optimal treatment is important. And making sure that if you're on prednisone, there's an intended end date of the prednisone. We need prednisone in the beginning. It's a miracle drug, but it's not a drug to be on for long. And, we had some discussions at the conference, and somebody was told by somebody that, if you are on prednisone and you have diabetes, you need to stay on prednisone. That's the drug for you. And you need to just manage it with insulin. This is not what we do. This is not what we do. And if that's the answer that you were given, you really need to seek a second opinion. It's bad for your eyes. It's glaucoma, cataracts, glaucoma, especially in African Americans. It thins the bones, fractures, and osteonecrosis, where you get like sort of heart attacks in the bone, and that's a lifelong disability. Issues that happen with your skin, staying on moderate doses of prednisone affect your cardiovascular health through many pathways, not just because you get steroid-induced diabetes. It destroys your sleep for many people. It destroys your mood, so you don't even know who you are sometimes, and you're just living a lot of the time feeling grumpy and dissatisfied, and that's no way to live, and you really need an ally in your physician. And it's one of the most important points of advocacy.
Well, thank you so much. We really appreciate you taking the time to be part of our webinar and all the things you do for everyone in the myositis community. Thank you so much.
Thank you. And thanks everyone for sharing these awesome questions. And it's always awesome to meet folks at conference, and it's very enriching for all of us on the medical advisory board when we meet you. And I want to say thank you to Rachel, because she's one of the best interviewers ever.
Thank you. All right. And I want to thank those of you out in the audience for tuning in. Please tune in next week, next Thursday, March 23rd, from 6 to 7 p.m. We will have an empowerment clinic on living with dermatomyositis. That is a different format from Ask the Doc, and it's really engaging because you not only get an expert in Dr. Julie Pack, but you also get to speak with a TMA community ambassador that has had DM for 25 years. So we hope to see you next week. For TMA, I'm Rachel Bromley. Good night.